Saad, for this great introduction. I don't deserve this introduction, but I would like to thank the Mega Online team and the army behind this great work and the iconic symbols of this group, Dr. Saad Mahdi, for his invitation to be a moderator for this session. Our speaker today, as Dr. Saad is exceptional, and he's well known in a member of Anaesthesia community, and he's certified from Ain Shams University, I think, if I'm not wrong, 1979.
Yes,
and
yes.
this is what's called the greatest people just came from this line and getting a position everywhere. And he's now a professor of anesthesia and the ICU and pain management in the same university, in Shams University in Cairo, Egypt. He's a senior scientific committee in the anesthesia department, and he has many activity. Really, when I ask him, how can I introduce you? He's a very simple professor, just tell me that professor in university. But I found it shame to me just to see that, because he deserves more. And also he has many activity face-to-face and online. And our topic today is exceptional. This is something related to physics, and as a physician or a medical doctor who don't like in physics and mathematics, but he makes something, the topic really to be touched by many and to feel it harsh, and you can't understand. But with Professor Raafat, last week I attended a presentation, and from the beginning I feel it's very difficult to understand, but really Dr. Raafat make it very easy and transfer very easy to me, and I feel it palatable, and I was interested and very happy to be a moderator for this today, for him to just to be as attendant to listen for the second part. And I think it's very important for all candidates and for people just going to the exam, because this is a difficult area when you're asking me about physics. And now for Professor Raafat Abdel-Azim, just for the second part of the presentation, and still for you, Dr. Raafat. Thank you.
Assalamu alaikum, everybody. Thank you, Dr. Saad. Thank you, Dr. Yasir, for this introduction. I'm very happy to meet you again. Hope, inshallah, we'll meet again and again. In a few minutes, I will summarize what was given before to continue the topic without confusion. As you said, the anesthesia ventilators is a very important part of our practice. I categorized the ventilators into three categories. The first one, which is essential to understand first before going to the newer versions. This is what we call traditional ventilators or ascending bellows ventilators. These are examples of the ascending bellows ventilators. Other ventilators, in ascending bellows ventilators, we can see the bellows going up and down. Other ventilators are, for example, Draeger, and in other ventilators, we cannot see the bellows. There is a different mechanism for operating the ventilator. In older ventilators, I already gave a hint about the older ones. I said I will summarize some important points. The first one is the ventilator replaces my hand and the reservoir bag during manually assisted or manual controlled ventilation. The power of my hand is replaced by the power of the driving gas, that is compressed oxygen under high pressure, and the reservoir bag is replaced by the bellows, which contains the patient gas inside. This is a respiratory cycle, which constitutes of inspiration and expiration, and there should be a cycling from inspiration to expiration and cycling from expiration to inspiration. And this cycling depends on achieving either tidal volume or time or pressure or flow, as I will say later. To start mechanical ventilation, we have to push the button of start or having it in on condition. When we switch to on, we have to connect the ventilator by a hose or switch back ventilator switch or lever or selector. And in newer versions of ventilators, these two steps of connecting a hose or selecting a ventilator is shortened and no need to do this. All conditions, the APL valve and the bag are isolated or should be closed in older versions. So don't worry about the APL valve and the reservoir bag after starting mechanical ventilation. This one I didn't mention before, but everybody knows that the units of measurement of pressure are in different forms. And we have to know what is 1 atmosphere. That equals to 1 bar and equals to 760 millimeter mercury, 14.7 psi, 100 kilopascal, or 1030 centimeter water. Because in different areas, we use different units of measurement, but the standard unit is the kilopascal, of course, as you know. I said that the flow arrangement in the anesthesia machine is divided into 3 parts of pressure, different pressures. The high pressure in the pipeline and oxygen cylinders, the intermediate pressure, that is 4 bar inside the machine, that's used in different areas. And our concern now is about the ventilator. So it is operated by oxygen in a pressure of 4 bar or 4 atmosphere. After that, the oxygen is subject to second stage reduction, reaching just above 1 atmosphere to go through the vaporizer and flow meter vaporizer and the fresh gas outlet. These are the different pressure areas. In each machine, it will be written there, the operating pressure. This one is important to understand. Oxygen is coming under 4 bar pressure, going inside the ventilator. This is the back or the rear view of the ventilator. The control panel will be supplied by oxygen under pressure of 4. Then it will be operated, and I will adjust the parameters of ventilation. The output, that is the tidal volume, will come into the hose, coming inside the chamber containing the bellows to compress it down to push the contents of the bellows into the inspiratory limb of the breathing circuit into the patient's lung. The ventilator, the traditional or the ascending bellows, consists of control panel and bellows assembly. The bellows assembly is a rigid housing, transparent, containing the bellows. The patient gas is what the patient gas is the patient gas, the gas coming from the patient's lungs through the expiratory limb to expand the bellows, and that is again compressed down to be pushed again into the patient's lung. The patient lung and the driving gas, that is pure oxygen, inside the chamber don't mix. The drive has only one function, that is a compression of the bellows. We have 4 valves to operate the ventilator. That these are the flow valve that should be opened during inspiration throughout the inspiratory time to allow the driving gas to come into the chamber to operate to compress the bellows. The other three valves are the safety or the overpressure valve that opens if the airway pressure is high to any reason at any time of the respiratory cycle. It will be open for safety, and I adjust the pressure to whatever according to the patient's condition. Usually we start with 40 or 35 centimeter water. The gas coming through this overpressure valve is pure oxygen, and it will go into the atmosphere. The other valve is the exhaust valve that opened during expiration. As we see, we start ventilation. Flow is the driving gas coming into the chamber inside, and it will compress the bellows downward. The content of the bellows will come to the inspiratory limb and into the patient's lung. Only the flow valve is open and the other valves are closed. This is the situation of the mid-inspiration. This is the end of inspiration. The flow valve will be closed and all other valves are also closed. After that, the patient's lung will be allowed to deflate and the bellows will come upwards containing the patient's gas or the expired gas. When it goes up, the driving gas inside the chamber should be vented, and this will be done through the exhaust valve, which opens throughout the expiratory time, venting the driving gas into the atmosphere. At the end of expiration, when near the end of expiration, when the bellows is coming up more at the end of expiration, the spill valve will open to vent the excess patient gas that contains anesthetic, carbon dioxide, and water vapor. This will be vented into the scavenging system to prevent pollution. The spill valve. This is a summary of the 4 valves that operate the ventilator, what time they open, what time they close, and what is the gas coming through it, and where is the fate of this gas. This is a very important point. The ventilator pushes its content, this is the tidal volume, into the breathing circuit. So there is a connection into the breathing circuit. The breathing circuit consists of inspiratory limb and expiratory limb, starting with inspiratory valve, and this is the expiratory valve. Each valve allows passage of gases in one direction only. So the inspiratory one into the patient's lung and the expiratory valve out of the patient's lung. At a certain point, the fresh gas flow that is coming from the flow meter into the vaporizer, coming out of the fresh gas outlet. This one contains oxygen and inhalation anesthetic. It will join what is coming from the ventilator, joining each other and go together into the patient's lung. If I close the fresh gas flow completely, the ventilator will not stop its function. It is going on, and the contents will not contain oxygen and inhalation anesthetic. So there will be 2 effects. These are hypoxia and awareness of the patient. So the fresh gas flow is essential for the patient, but it's not essential for the ventilator operation. This is the situation during inspiration. The inspiratory limb is open, the inspiratory valve is open, the patient's lung is inflated, the ventilator bellows is going down. It will go through the tubing into the inspiratory limb, passing through the carbon dioxide absorber to get rid of the carbon dioxide that was coming through the previous expiratory time. This is the expiration in which the patient's lung will be deflated. The contents will come through the expiratory limb, expiratory valve into the bellows. It will ascend up, it will be completely inflated, and the excess gas will go to the spill valve to be vented into the scavenging system. we call it excess because all the time during inspiration, the fresh gas flow will go to the patient, and during expiration, the fresh gas will go into the spill valve. So the contents of the spill valve, the contents vented by the spill valve in a system with no leaks equals the fresh gas flow. The parameters of ventilation are the inspired oxygen concentration or FiO2 fraction of inspired oxygen, tidal volume, frequency or rate, minute volume, IE ratio, that is the ratio of inspiration to expiration, and inspiratory flow rate. At a certain time, after a few minutes, I will explain what is inspiratory flow rate. It is not there in all ventilators. In some ventilators in which I cannot adjust the inspiratory time or expiratory time, there is a option of inspiratory flow rate. I will explain it later. Some ventilators have the parameters of tidal volume, frequency, and IE ratio, and the tidal volume in other ventilators is not there, but we can divide the minute volume by the rate to have the tidal volume. There is something that is called inspiratory pause to inspiratory time ratio, because I said before that there is a part of the inspiratory time that's called inspiratory pause, in which the ventilator stops its flow, and this part sometimes it is not there. I can create, or it is there and I can adjust its duration. So the duration will be displayed here as a fraction of the total inspiratory time. Now I'll start today's session. This explains the relationship between volume and time. The tidal volume is here, it's displayed on the vertical axis as a number 100, 200, 300, 400, 500. The peak of the here, this one represents the tidal volume, and the horizontal axis is the time. So during each cycle, there is an inspiration, inspiratory time, and expiration. This one is the inspiration, and this one is the expiration, the descending limb. If the total respiratory cycle time is 3 seconds, this means that the rate is 20. We divide 60, that's 60 seconds, divide by the rate to have the respiratory cycle time, or divide the 6,000 by the total respiratory cycle time to have the rate. So if the respiratory cycle time is 3 seconds, the rate is 20. These 3 seconds in this example here are divided into inspiratory time that is half second and expiratory time that is 2.5 seconds. Go to the table here. If I give the tidal volume of 500 milliliter, if the rate is 20, this means that the respiratory cycle time is 3. It is divided into inspiration and expiration. Having 500 milliliters to be given in half second means that 1 liter will be given in 1 second. 500 in half second means 1 liter in 1 second. So the inspiratory flow rate here is 1 liter per second, because they are 60 liter in a minute. So it is 1 liter per second, 1,000 milliliter per second. When the flow rate here, in this example, in red line, is giving 500 milliliter in half second, it means that it is 1 liter per second. So the inspiratory time is half second. I don't have the option in this ventilator to adjust the inspiratory time. So if I adjust the inspiratory flow rate by increasing or decreasing, I can, here, the maximum flow rate, I can reach the point of having the exact time of inspiration and expiration. In this red line, the inspiratory flow rate is 1 liter per minute. If I decrease it, decrease means having more time to deliver the tidal volume. More time means slowing the flow rate. If I slow down the flow rate from 60 liter per minute to 30 liter per minute, that is halving. So instead of having 1 liter per second, it is 500 milliliter or half liter per second. It is the same tidal volume of 500, but it is delivered in a longer time. Instead of being half second, it will be 1 second. In the first example, the red line, the inspiratory time is half second and the expiratory time is 2.5. It is the same rate of 20, but in the first example, the inspiratory time is half second, the expiratory time is 2.5, so the ratio is 1 to 5. If I decrease the flow rate from 60 to 30 liter per minute, this means that the inspiratory time would be 1 second, expiratory time will be 2 seconds, and the ratio is 1 to 2. So the red line is a ventilation in 20 minutes rate, having tidal volume of 500. The blue line is the same 20 per minute, same tidal volume, but the inspiratory flow rate is slower. Slowing the inspiratory flow rate means prolonging the inspiratory time and shortening the expiratory time. So the ratio here is different according to each value of inspiration and expiration. If it is not clear, please tell me. We classify the ventilators according to many points. Never mind now with these areas. But the more important is the pressure versus volume ventilators. In pressure ventilators, we adjust the tidal volume and we measure the pressure. In volume ventilators, we adjust the, sorry. In volume ventilators, we adjust the volume. I didn't change my words, it is the same, but this area is not for this purpose. In volume ventilators, we give volume and we measure the pressure. If there is any change in resistance or compliance, I will explain later, there will be change in the other parameter. So for volume ventilators, I adjust the ventilator, but any change in resistance and compliance will affect the pressure, and the reverse in the pressure ventilators. Volume ventilators are commonly used in most of the anesthesia ventilators and in ICU. Pressure ventilators are used also in anesthesia, but for neonates, and I'll explain later. Here, the volume ventilators in the top view are this one, volume ventilators. I adjust the volume and I measure the pressure, and pressure in pressure ventilation, I adjust the pressure and measure the volume. Another classification, this is the anesthesia ventilators here, down. The upper one is the ICU ventilator here. There is no, in ICU ventilator, there is no bag and breathing, the breathing circuit is not including the bellows and reservoir bag, or the what we call the bellows. So no bellows, no bellows and no reservoir bag, and no here. This circuit is here also. So combining the circuit with the ventilator will, this one, combining the one on the right side up into the one on the left side, ICU, giving the anesthesia ventilators that we call double circuit. Why we call double circuit? Because there is a circuit inside the ventilator here and a circuit outside the ventilator, that is the breathing circuit, so it is called double circuit. Also, there is another another description ascending bellows ventilators and descending bellows ventilators. Descending bellows were used before, and the attaching point was at the top of the ventilator, and the ventilator will go, the bellows will go down during expiration and will go up during expiration. We give the name ascending bellows during expiration, descending bellows during expiration. So the one on the left side is the commonly used now. This is the ascending bellows ventilator that the bellows will go up during expiration. We stopped using descending bellows ventilator because before there were no visual or auditory or electronic alarms, and we were obliged to observe the movement of the bellows all the time. If there is disconnection, the bellows will, in the descending bellows ventilator, if there is disconnection, the bellows will go down by its weight, and it will go up by the driving gas, even with the presence of disconnection. So it is stopped. Here we can see two types of ascending bellows ventilators. These are Omida, and the other one is Draeger with ascending bellows. But the movement of the bellows starts on the one on the right side. It starts from the top. The grading or the scale starts from the top by 0, 200, 400, and so. So it will go during inspiration from this point down to reach the set tidal volume. During expiration, it will go up. It is an ascending bellows ventilator. This one is also ascending bellows ventilator, but the start of an inspiration is from a certain point at which it is the expired tidal volume coming from the attachment is also from down, but the movement is from this point of expired tidal volume downwards. The video will explain more. So both are ascending bellows ventilator, but the starting point in Omida is from the top of the chamber, and the starting point of Draeger is from the set tidal volume. Each of these ventilators will give the preset tidal volume, but the difference is that in Omida ventilator, the bellows is fully inflated at the end of expiration, fully inflated. At the end of inspiration, it is partially deflated according to the tidal volume. In the Draeger ventilator, it is partly inflated at the end of inspiration and fully deflated at the end of expiration. The video will make it more clear. Both are ascending during expiration, but the starting point is different, and the situation at the end of inspiration or at the end of expiration is different. This is a comparison between Omida and the Draeger according to the point of attachment and the state at the end of inspiration and the end of expiration. The interaction between the ventilator and the breathing circuits appears as a difference between the preset and the delivered tidal volume. Of course, we adjust the preset tidal volume according to the body weight of the patient. For example, if it is 500, this is the preset delivered. The preset tidal volume is 500. But what is given actually to the patient will differ according to two factors. These two factors, the first one is the effect of circuit compliance that will lead to loss of part of the preset tidal volume. So the delivered tidal volume will be less than the preset. The other factor will add, this is the effect of fresh gas flow, and this fresh gas flow will add to the preset tidal volume. So it is not always the situation of having the delivered tidal volume the same as the preset. Something will subtract and something will add. Circuit compliance means the expansion of the circuit due to the positive pressure. This expansion will lead to loss of some part of the tidal volume delivered to the patient. And the fresh gas flow, of course, it is addition, as I explained before. The effect of circuit compliance depends on the compliance of the circuit, the material, the manufacturer will supply us with the compliance. That means how much is the circuit will expand by volume in relation to the pressure. It is called circuit compliance. The other factor, that the first one is the material, how much it is compliant, and the other one is the peak inspiratory pressure. Whenever the pressure increases, the pressure will lead to more expansion of the circuit, and this lead to more loss, and the delivered tidal volume will be less. The ventilator tubing is more compliant in anesthesia breathing circuit, and it is less compliant in ICU because in most of the ICU patients, the peak pressure is high in asthmatics and COPD and other forms of respiratory failure. We usually meet patients with high pressure. So if the circuit is highly compliant, this will lead to too much loss. The circuit compliance in anesthesia ventilators may reach to up to 9 milliliter per centimeter water. This means if the airway pressure is 10, there is 90 milliliter of volume lost. If it is 20, there is 180 milliliter of loss. This cannot be met in ICU ventilators because of the low compliance of the breathing of the circuit of the ICU ventilator. So the delivered tidal volume here delivered will be preset minus the volume lost by the circuit compliance. The volume lost by the circuit compliance is the product of peak inspiratory pressure times the circuit compliance. As I said before in the last example, if it is 9 and the airway pressure, the peak is 20, it will be 180. Go here. So the preset minus what is lost due to circuit compliance will lead to the delivery of the delivered tidal volume. But we have always to subtract the PEEP, the P in the expiratory pressure if it is positive. So for example, if the delivered, the preset tidal volume is 500, the delivered will be less than 500 if this one is 20, and the circuit compliance, if it is 9, so 180 will be lost, and the delivered tidal volume will be 320 only. The higher the compliance, the more loss. The higher the airway pressure, the more we lose from the delivered, the preset tidal volume. In ICU ventilators, this effect is less and less because of the low compliance of the breathing circuit that is made from different materials. Volume loss is important, but it is more important in patients with very high peak inspiratory pressure. That is, for example, ICU patients or any patient in the operating room with high airway pressure at any time during operation. It is also important in patients with a small tidal volume. Why? Because, for example, in neonates, if a neonate is only 4 kilograms, this means the tidal volume is, for example, if it is 7 milliliter per kilogram, it will be 28, or 7.5, it will be 30. With high pressure, the loss may exceed the tidal volume. So nothing will be given to the patient. That's why we ventilate neonates with pressure limited ventilation to stop the effect of the high pressure on the loss of the tidal part of the tidal volume. Again, the interaction between the ventilator and the breathing circuit is the relationship between the preset and the delivered tidal volume. There is a difference. The difference is that some part of the tidal volume is lost due to the effect of circuit compliance, and some part will be added due to the effect of fresh gas flow. The effect of circuit compliance depends on the compliance of the circuit, the material itself, and the peak airway pressure. The higher the compliance, the more loss, and the higher the peak airway pressure, the more will be lost from the preset tidal volume. Effect of fresh gas flow means that, as I said before, the ventilator is giving the preset tidal volume to the patient through the inspiratory limb. At a certain point, the fresh gas flow will join the output of the ventilator and will go together. The addition will go together into the patient through the inspiratory limb. But not all the fresh gas flow. It is the fresh gas flow is during the whole time is giving its output, but only it is allowed only to go inside the inspiratory limb during only the inspiratory time. The rest of the respiratory cycles, that is expiration, the fresh gas flow will go into the spill valve. So part of the fresh gas flow will go into the inspiratory limb during the inspiratory time only. How to calculate it? This is a fraction of inspiration to expiration. So the inspiratory fraction is, if the inspiratory to expiratory time is 1:1, this means that inspiration is half the respiratory cycle time. If it is 1:2, this means the inspiratory fraction is 1/3. And if it is 1:3, it is 1/4 or 1/4. The inspiratory fraction of the respiratory cycle depends on the time of inspiration to the total inspiratory time. We can obtain it by dividing 60 over the frequency or the respiratory rate. Inspiratory time means, for example, if the frequency is 20, inspiratory time will be 60 over 20, it will be 3 seconds. Example here. This is the duration, inspiratory time. This is the duration. And here the example is the, here is the fraction. Forget about the fraction now. To make it easier, calculate the inspiratory time. If the rate is 20, it means, and the IA ratio is 1:2. If the rate is 20, so the respiratory cycle time is 3 seconds. If the ratio is 1:3, so the inspiratory time is 1 second. 1 second inspiratory time means this is the time allowing part of the fresh gas flow to go inside the breathing cycle. So in 1 second, the fresh gas flow will go into the inspiratory. If the fresh gas flow, for example, we adjust the flow meter, I giving 6 liters per minute. If the flow meter is adjusted to give 6 liters per minute, whatever it is, oxygen or oxygen plus air or oxygen plus nitric oxide, it is 6 liters. These 6 liters are given during 1 minute. So in 1 second, we divide by 60 seconds to give 100 milliliter per second. So the flow rate of 6 liter means 6,000 milliliter per minute. 6,000 milliliter per minute, that is 6,000 milliliter in 60 seconds. 6,000 milliliter in 60 seconds means 100 milliliter per second. So this second, if the inspiratory time is only 1 second, so the addition will be 100. If the inspiratory is 1.5 seconds, this means that 150 will be passing into the inspiratory limb. So depending on the inspiratory time and the flow rate. So the effect of fresh gas flow is that what is the fresh gas flow rate and what is the inspiratory time. If the fresh gas flow rate is 6 liters per minute, it means that it will give 100 milliliter per second. calculate the inspirator time, and the product of this addition times the inspirator time will give the part of the fresh gas flow that goes into the inspiratory limit. The volume added here in this example of having 1 second inspirator time and 1 milliliter per second of the fresh gas flow rate, giving 100 milliliter per time added to the tidal volume. At a certain inspiratory rate, decreasing the frequency will lead to increasing the inspiratory time. For example, if the respiratory rate is 20 and the inspiratory time will be 1 second, if the decrease the rate into 10 only, this means the respiratory cycle is 60 times by 10 divided by 10. The respiratory cycle time will be 6 seconds divided into inspiration 2 seconds and expiration 4 seconds. So the inspiratory time would be 2 seconds. In 2 seconds means that we multiply 2 here, 2 times 100 ml if the fresh gas flow is 6 liters per minute. 2 times 200 will be times the 100 will be 200. So whenever we decrease the frequency, this will lead to increase in the inspiratory time and increase in the volume added. To summarize, the volume added depends on the fresh gas flow and the inspiratory time. More fresh gas flow, more addition, more inspiratory time, more addition. The volume added is important. It is more important when we make large changes in fresh gas flow rate. These large changes can be obtained, for example, during if we press the oxygen flush during mechanical ventilation. Always don't initiate the oxygen flush during the mechanical ventilation, especially during the inspiratory time. It will add much to the tidal volume. The flow rate during activation of the oxygen flush may reach up to 75 milliliter per minute. The other important point is during delivery into the delivering small tidal volume, like for neonates, changing from changing from fresh gas flow rate, for example, from 1 liter to 5 liters per minute, will double the tidal volume, and this will lead to barotrauma. That's why we give pressure limited ventilation in neonates. Finally, the delivered tidal volume will equal to preset tidal volume minus the volume lost due to circuit compliance plus the volume added due to the effect of fresh gas flow. Now we have newer ventilators with what is called fresh gas flow independent of ventilation. Why independent? Because the fresh gas flow will add. So to avoid addition from the ventilation, we do something according to the manufacturer of the ventilator, something to stop this relationship between the fresh gas flow and the delivered tidal volume. This can be obtained according to the manufacturer. Here in General Electric, we have something called fresh gas compensation. We'll see in the next video the effect of fresh gas compensation. What is fresh gas compensation? It compensates for changing the fresh gas flow by active feedback controls that controls the bellows movement. We'll see. Control the bellows movement to stop the effect of the fresh gas flow. So whenever we change the fresh gas flow, the delivered tidal volume will be exactly or not near approximating the preset tidal volume. In another manufacturer, that is Mackay flow, they do something different. That's fresh gas accommodation. In Draeger ventilators of Zeus and Perseus, they have what is called ventilation by circuit flow interruption. And in Draeger, Cicero, Fabius, and Primus, we have the fresh gas decoupling, and I will describe in detail. So we have different mechanisms according to the manufacturers of the ventilator to stop the effect of addition of the tidal volume, to stop the effect, to stop the occurrence of barotrauma. So we have something that stops the addition of fresh gas flow to the preset tidal volume, to stop augmentation of the tidal volume. I put these two in red because these types of ventilators are available in Egypt. So I will explain more, describe in more detail. The fresh gas compensation in General Electric ventilators will be explained in this video. In this video, we'll see the preset tidal volume here of 500, and we will see the delivered tidal volume that will be affected first in the first few cycles by increasing the tidal volume. The delivered tidal volume will increase, but by activation of the automatic, of course, activation of the fresh gas compensation after a few cycles, it will adjust the preset tidal volume. It will adjust the delivered to be approximating the preset. You see now, the preset is 500, and the delivered is 480. The ventilator is going down. Here, the fresh gas flow is 2 liters. If we increase the fresh gas flow from 2 liters to 6 liters, this will, of course, add to the delivered tidal volume. And now you see it will go up. It is now for 540. The fresh gas compensation will be activated. It's going again up. Then the fresh gas compensation will work now to let it go down and to be again near the preset tidal volume. It is only 3, 4, 5 cycles going down. I'm doing nothing now. It's only observing. So again, it is near the preset tidal volume as before. The reverse will occur when we decrease the fresh gas flow. You see the delivered here is 480, approximately the 500. The fresh gas flow is 6 liters. If we decrease it from 6 liters to 2 liters, this means that the effect of fresh gas flow will go down. The delivered tidal volume will decrease because of the decrease in the fresh gas flow. But the fresh gas compensation will push it up again to be close to the preset tidal volume. This is fresh gas compensation. Again, it is here near the preset. In the regular Cicero or Primus or Fabius, we have what's called fresh gas decoupling. Fresh gas decoupling means that separation of the relationship between the ventilation and the fresh gas flow, decoupling. By decoupling, we have two things have been done in the ventilator, two changes. The first one, you can see here, this top, this one, as I displayed before. This is the scissor ventilator. This is the cover here. When I cannot see the ventilator here, I cannot see bellows. The bellows is replaced by what is called piston. This piston here, when I remove the cover of the ventilator, I can see this one. This is the piston. By activating the video, you can see the piston moving in a horizontal movement. It is mechanically operated. It is not pushed by the driving gas. You see now the video. Now the piston is moving, delivering what is inside the piston into the patient's lung. During the routine use of the ventilator, I cannot see this piston and most of the ventilators of the piston, but I will show you how to see. Here we can remove our undo covering of the anesthesia machine. I remove the cover. I can see the piston inside. In Fabius ventilator, it looks like a bellows, but it is not bellows. The video will show it clearly. This is the piston, the diagram showing the piston. Moving to the left, moving the piston to the left, means that the contents of the piston, that's the patient gas, the contents of the piston here, excuse me, the contents of the piston will go to the patient into the inspiratory limb. This depends on the distance. I move it here according to the preset pedal volume. This movement is only mechanical. It doesn't depend on the driving gas, as I said before, for the ascending bellows ventilator. So the first thing with this manufacturer have achieved is removing the bellows and replacing it with a piston. The second thing is applying what is called fresh gas decoupling. This fresh gas decoupling valve is inserted between the reservoir, what is coming from the fresh gas flow during the ventilation with traditional volume, traditional ventilators or ascending bellows ventilator. During the inspiration, the fresh gas flow will go into the inspiratory limb without any obstacle. Will go direct into the inspiratory limb. But here, with the application of fresh gas decoupling issue, there is what we call decoupling valve. The decoupling valve will be closed during inspiration. So the fresh gas flow will not be directed into the inspiratory limb, but it will go into the reservoir bag. I said before, when I described the action of the traditional ventilators or ascending bellows ventilators, that whenever I start mechanical ventilation, the reservoir bag is isolated and it doesn't move. Observe the reservoir bag during mechanical ventilation using ascending bellows ventilators. You will see it not moving because it is isolated. But in case of using fresh gas decoupling, it expands during inspiration. Why it expands? Because the fresh gas flow is redirected. It is not going into the inspiratory limb, but it will go into the reservoir bag. So during inspiration, the patient is not given what is coming from the fresh gas flow, but it will be here stored in the reservoir bag. What will be given to the patient is the content of the piston. During inspiration, it will go into the inspiratory limb, inflating the patient's lung. So during ventilation with fresh gas decoupling system, you will see both are inflating during inspiration. The patient's lung, because of what is coming from the ventilator, and the reservoir bag because of what is coming from the fresh gas flow. Of course, fresh gas flow will contain oxygen and inhalation anesthetic. During expiration, the decoupling valve will open, allowing gas from the fresh gas flow and from the reservoir bag to come into the circuit, but not in the direction of the patient, but to the direction of the piston, because during expiration, the piston will move to the other direction, extracting what is coming from the patient's lung. So the expired volume will come into the expiratory limb, into the piston, and it will fill again the piston according to the preset tidal volume. So this one will be filled with the expired patient's gas, in addition to what is coming through the open decoupling valve, adding from the fresh gas flow and the reservoir bag. So the reservoir bag will be deflated during expiration. Both the patient's lung and reservoir bag will be deflated during expiration. So what is done for fresh gas decoupling system is having piston instead of bellows assembly and addition of the fresh gas decoupling valve that closes during inspiration and opens during expiration. Now we see in this video in the Cicero anesthesia ventilator trigger that the fresh gas will move into the reservoir bag, inflating it during inspiration. At the same time, the patient's lungs are inflated. For activating the fresh gas decoupling systems, the manufacturer has designed the ventilator to have either piston type that I described before, or descending bellows that we stop using it in the traditional ventilator. Because the ventilator piston bellows, the piston unit or bellows in either of these types refills under slight negative pressure, so it allows the accumulated fresh gas flow to move from the reservoir back into the breathing circuit during the next ventilator cycle. So oxygen and inhalation anesthetic stored in the reservoir bag will go inside the piston during expiration and to be delivered into the patient into the next inspiration. It is not possible to use the fresh gas decoupling with ascending bellows ventilators. The advantage of fresh gas decoupling is to decrease the risk of barotrauma and volutrauma. Because there is no addition. There is a risk of entraining the room air. I will show you now. There is additional valve here that is called negative pressure release valve. Negative pressure release valve. It's important appears when we use very low rates of fresh gas flow. This reservoir bag will not be expanded as much as desired. So during inspiration, all of its contents will go into the during expiration, this one, the contents will go into the piston. If it is too much low, so on moving the piston with negative pressure to take the patient's gas side, if all the patient's gas comes out and this one is completely collapsed, so there is negative pressure here. If still the expired time still the piston moving, so the negative pressure will be applied to the patient's lung, causing negative pressure pulmonary edema. To prevent this negative pressure pulmonary edema, the manufacturer has introduced a negative pressure release valve here to get air from outside inside to prevent applying negative pressure on the patient's lung. So this negative pressure relief valve is a safety measure to guard against development of negative pressure pulmonary edema. Of course, this may lead to a dilution of the contents of the piston. I will stop here because only now it is 1 hour. Thank you, Dr. Yasser.
Thank you, Dr. Raafat. And now it's still the time for asking the expert. You know that after speaking, you know that it's like a series and to continue. Dr. Raafat spoke about the idea behind the ventilator, the primitive one, and the prototypes, and now with the advanced one, and what happened for the gas in the circuit to go to the patient. As usually we don't think about it. You just do every day and you don't think about it, but it's like a root of the tree. If you have a tree without the roots, it will be fall down easily. So you must know behind everything. So it is a time now. There is a room for question, and anyone have any question can put in the question and answer. But really, I have many questions. Even I asked the question last time, but I was thinking that I'm waiting for this time to ask this question. But I asked this question last time, but I don't get an answer.
Yes,
You know
still we
that,
have 2, 3 presentations more.
so I ask at the end.
Yeah, okay.
Also, there is a trend now for the ventilation for pediatric. Before it is like something forbidden, you must use a pressure control. But now it is a trend or tendency for pediatric anesthesia most of the time to use a volume control. And when I
Yeah.
asked him, he said because the ventilator become more safe and adjust the pressure and they will not go beyond limitation. What's your opinion about that?
Of course, it is you are the one to master the technique, whatever you give to the patient. But always consider the effect of fresh gas flow on the delivered tidal volume. If you are considering that and you are monitoring the delivered tidal volume and the airway pressure, do whatever you master.
Yeah, thank you. Again, you speak about the preset volume and the real volume which come into the patient.
Yeah.
What is the permissible difference we can accept in our ventilator? For example, if I adjust it for 500, what is the permissible I can accept for this ventilator when to go to the patient, for example, 400, 450 or more?
Yes. In my opinion, it is not written there anywhere in the literature, but in my opinion, it is within 10% of the preset tidal volume.
That's
It
okay.
is only
Thank
my
you very much.
opinion. Yeah.
Yeah, we do that. We don't have, if you don't have an evidence, you have an opinion on that.
Of course, you adjust your settings. Excuse me. You observe your ventilation, as I will say later, by capnography and saturation. So if the capnogram doesn't give the desired CO2, you adjust, readjust, increase or decrease.
This is another question related to our presentation. What is the best setting for a patient obese like me, or just and have COPD or head down position? What is the best setting for our ventilator? IA ratio, volume. What is the mode for ventilation is the best for these people?
Yeah, you don't look obese. Of course, in the literature, you can differentiate between the ideal body weight, the lean body weight, and the total body weight. Of course, it is not the total. It is not the total. It is
Yes,
usually you adjust by the ideal, and we adjust again by the capnography. The goal, as I will describe later, the goal is to have the desired CO2. The desired CO2 is the main goal of ventilation.
A last question here. Do you think if you go for a new place that sometime you go that like a lost when you use another ventilator, do you think standardization can help in safety or just an orientation? Because sometimes you go for another place and you don't use this machine, I don't know anything. And do you think standardization will be a good idea just for for the safety of the patient?
You mean standardization of what?
Of the machine in every place, because it may be, and
yes,
safety.
I'm
So
with you. I agree with you. I agree with you. For example, in one hospital, there is standardization all over the country regarding the outlet on the wall outlet of the pressure of the connections. But for the use of certain types of machines, I prefer, for example, if I am working in a hospital with 10 ORs or 15 or 20, I prefer to have the same type of anesthesia machines for everybody to be aware of using it, and if there is any part that is lost, to be replaced. But of course, if you have good types of anesthesia machines, the malfunctions will be less and less, and you can have more than one type. But I agree with you with standardization. If you mean what I have understood.
Yes. Really, Dr. Nagy Nigma, our colleague and our professor also, he asked, but I don't understand the question. He said compensation, why not? I don't understand, You understand what is the
compensation
question?
of what?
Why not?
Why not compensation?
Yes, compensation, why not?
Yeah.
And
if I understood what he meant, why
Really, I
not?
don't understand.
Why not compensation means that why we do compensation. If you don't have compensation, this means that changing the fresh gas flow will lead to change in the preset tidal volume, in the delivered tidal volume. So if you are observing what is given, you can do it manually. You adjust the fresh gas flow. You don't need the 6 liters per minute. All this is lost. I will describe later that you need only half liter only of fresh gas flow. If the system has no leaks and everybody is controlled, the soda lime is not exhausted and there is no leak, you need only fresh gas flow of half liter. Increasing from half liter to 1, 2, 3, 4, 5, 6 is a waste. The oxygen and the anesthetic will go out. So the only hazard that you have is that the maximizing the tidal volume has no benefit to the patient. It will lead to barotrauma. So we have to adjust the fresh gas flow. We have to consider its effect of changing. This effect can be done automatically by having fresh gas compensation in these types of ventilators. It will be automatically seen. If you don't have this compensation, you can do it manually. If you increase the tidal volume, increase the fresh gas flow, and it affects the tidal volume, readjust tidal volume or readjust the fresh gas flow.
Another question from our colleague and Basma Abdurrahman. She asking, is this technology of compensation used in ICU frequently, or this is not used in ICU?
No, we don't need it in ICU because there is no fresh gas flow in ICU. No fresh gas flow, no flow meter. The delivered tidal volume is what you adjust, or it is the preset in ICU ventilators. It is the preset. The effect of loss due to compliance of the circuit is minimal because of the material is not compliant. And no addition in ICU.
Our colleague Sayed Ahmed, he asking about, do you think we need a different bags for different ages? For example, group pediatric, neonate, pediatric, or just an adult. We need a different size bag.
This question is related to the topic of breathing circuits and not related to the topic of ventilators. When you start the mechanical ventilation, forget about the bag. Alas, it is not contributing to the ventilation. So the size here has no effect. But in the breathing circuits, of course, using iris TPs, you have to have a small bag to control the relationship between the fresh gas and the expired gas. But during mechanical ventilation, don't be minded with that. But the tubing is important. The tubing, not the bag. The tubing.
Yes.
The tubing. If you are giving ventilation to neonates or pediatrics, you have to use pediatric tubing to minimize the effect of circuit compliance.
Just a question here about the auto flow control or pressure control volume guarantee according to the name. This is will come in the near future, or just you can answer now?
Yes, the modes. I will describe the modes, but the main item is the controlled ventilation. Controlled ventilation, because we are talking about operations. It is surgical situation, not ICU. For surgical situation here, it is controlled ventilation. Controlled ventilation by any means. Now I start with volume control and pressure control. I will describe later. And it's variance of pressure control, volume guaranteed. I will explain later, inshallah.
I think we need another 1 hour just for, because after this 4 hours, it will be a group of questions. It can fill this room of 1 hour, inshallah. But Dr. Nagy Nigma also, Professor Nagy Nigma is asking about which is better, decoupling or coupling with compensation?
It is manufacturers' requirements, not ours. But in my experience, the difference here is when we apply for purchasing anesthesia machine, we consider these technical points in addition to the price. Actually, the price of GE, I'm not doing propaganda for the ventilators, but its price is less. So we consider the price here. But for the technical points are not too different. They are not too different. Both have their advantages and disadvantages, and both are liable to malfunction at any time. But of course, the Rega technology is slightly higher than GE technology. So the coupling is okay, okay. But we all of us we work with both types of ventilators.
Yeah, I feel that the ortho ventilator is more durable. I just was working in ICU with a ventilator on the patient Siemens. Yeah. I am not promoting for Siemens, but it's a very old version. But it stay for the patient 3 months, working without tiredness, without any problem. But I think our machine now is like a very, very meticulous, very delicate, but liable for, like a computer, liable for any problems and give alarming and stuff like this.
The big difference in after Siemens is the display of parameters. Displayed the graphics and the numbers are not, they were not there in Siemens, the old Siemens.
Yeah. Yeah, thank you. Thank you, Dr. Raafat. I think no more question now, and we can just end this session. And thank you for your time and your effort to concentrate. Even for me, I'm concentrated, but I lost a lot for this equation because I'm not a math man, you know. But I just enjoyed to attend, and thank you for Dr. Saad, and thank you for everyone for today. And just waiting you on Friday for a session done by Cairo University about anesthesia for special bath. And we invited you all to attend this session. And thank you for attending and helping the MEGA online. And thank you very much for attending. Thank you, Dr. Raafat. And just waiting for the still 2 of the series,
of course,
because it is all or none rule. So we need the all, inshallah. And thank you very much for attending.
Thank you.
And this is the end of today. Thank you very much.
Thank you, Dr. Saad. Thank you, Dr. Yes, bye.
Thank you.